Hello and welcome. The topic of today's video is hyperthyroidism and hypothyroidism. We will start with hyperthyroidism. What we see is a list of all of the causes of hyperthyroidism, but the important fact to note is that Graves' disease is the vast majority. And one of the clinical rules of practical medicine is anytime something is more than 90%, it's all, and anytime something is less than 10%, it's none, until clinical circumstances force you to reconsider. So when a patient presents with hyperthyroidism, one should presume that it is Graves' disease until proven otherwise. The pathophysiology of Graves' disease is that it is a type 2 hypersensitivity, and this means that the antigen is fixed in the tissue, so that the antibody travels to the tissue where it's bound, activates complement, and the subsequent inflammation. In this case, the antibodies are TSH receptor antibodies, and they're immunoglobulins produced as an autoimmune disease by the lymphocytes. The signs are those of hyperthyroidism, which we'll discuss soon, but critically important are the extrathyroid findings of exophthalmos and pretibial myxedema. These are caused by the TSH receptor antibodies cross-reacting with the connective tissues of these sites, and they're not found in any other type of hyperthyroidism. The TSH will be suppressed by the T4 produced by the stimulated thyroid. A functioning adenoma is a benign neoplasm, and this benign neoplasm is functioning, so by definition it produces T4. When one looks for the signs, one can often palpate the nodule. But if you can't palpate it, you can go looking for it by ultrasound. It's producing T4, so TSH is suppressed. Hashimoto's is a type 4 hypersensitivity, which means it's mediated by cytotoxic lymphocytes which destroy the gland. The thyroid gland is very unique in that the hormone is stored in these colloid centers found in the thyroid tissue. And with destruction of the gland, one can get release of the preformed thyroid. So this is therefore only seen in early disease when there's normal thyroid tissue to destroy. The physical findings are not terribly specific, but the surface of the gland typically is irregular to palpation. This is a release of preformed T4, so TSH is suppressed. Choriocarcinoma is a neoplasm of the cytotrophoblast, and it releases beta-HCG. Beta-HCG can act as an analog for TSH, and therefore at very high levels it can stimulate the thyroid. As a carcinoma, it's always a neoplasm. When one looks for the sign, there are two places that one can grow neoplastic cytotrophics. One is in the placenta, and the other is the germ cell neoplasms. Now, germ cells typically are found in the gonads, but because these gonadal cells migrate from the yolk sac, one can occasionally find germ cells along their migration path, and those tend to be midline. Secretion of the T4 suppresses TSH. Struma ovarii is the finding of normal thyroid tissue in a germ cell neoplasm, which typically will be found in the ovary. Germ cell neoplasms can grow all of the cells, and therefore very rarely they can grow thyroid tissue that functions. On physical exam, one should be able to find an ovarian mass, and the TSH is suppressed. Exogenous hyperthyroidism, or factitial, is when there's oral ingestion of synthroid or T4. In this case, the pathophysiology is of an oral medication, and one of the clues to finding this is in lab testing, there is normal thyroglobulin levels. Thyroglobulin tends to be increased in normal conditions of hyperthyroidism produced in the thyroid gland. The signs would be non-unique to find, and because one's taking T4, there is suppression of TSH. Pituitary tumors are overwhelmingly adenomas, and remember this is going to be a secondary disease because the pituitary tumor is producing TSH. On the signs, one can go looking for the mass effect from the pituitary bilateral hemianopsia. Thyrotoxicosis has many symptoms, and a good way to think about them is to group them according to the effects of the thyroid, as we discussed in an earlier video on thyroid function. First is an increase in the basal metabolic rate, and this includes such things as temperature intolerance. Thyroid is a key hormone in making us endotherms, and it does this by making many of our energy-producing functions run less efficiency, and therefore, when we have high thyroid, we have a lot of internal body heat production. Being an endotherm requires 10 times the energy of being an exotherm, and so classic in these patients is they have a weight loss despite the fact that they have an increased appetite. There really aren't very many conditions in which one loses weight despite increased eating, and the other two critical are going to be in diabetes mellitus type 1, polyuria, polydipsia, polyphagia, and with malabsorption. And in adults, the commonest cause of that is going to be celiac sprue. The increased sympathetic activity and internal body heat makes the person warm and sweaty. There's a clinical rule that if you can shake someone's hand and they have a cool, dry hand, they do not have hyperthyroidism. The next group to think about is that the thyroid affects its changes disproportionately through the sympathetic nervous system in regulating temperature. And this increased sympathetic activity causes some of the most distressing symptoms in patients. And these include things like anxiety, tremor. You can see those correlate with increased reflexes on the physical exam. The eyes are affected and they have a very staring look. And then the cardiovascular system will show hypertension and an increased heart rate. The sympathetic nervous system, which affects temperature regulation for the thyroid, obviously works predominantly through the muscle system. So when one takes a look at the heart, it can be affected in hyperthyroidism. It can manifest as congestive heart failure, and it is common for these patients to have arrhythmias. Old people will often only show these arrhythmias, and so one of the classic findings is a patient with atrial fibrillation must always have a T4 level to prove that it's not due to hyperthyroidism. Skeletal muscle behaves the same as heart muscle, and so it's very common in these patients to have weakness secondary to atrophy. And then the general increase in activity affects the bones, and these patients develop osteoporosis. Occasionally, it can be acute enough that the patient will show hypercalcemia on the metabolic panel. So, if one suspects clinical hyperthyroidism, what is the pattern of investigation? Well, the first is basically the chemistry, which we've talked about before, which is going to start with the TSH, which will be suppressed, and the increase in T4. So that confirms a hyperthyroid state. The next way we think about it is to go to the physical exam. If the gland is diffuse, then one can go looking for TSH receptor antibodies, because those are seen in Graves' disease. One looks at the anterior legs for pretibial myxedema, and then in the eyes, exophthalmos. And if those are all present, that establishes a diagnosis of Graves' disease. By comparison, one can find a nodule. And the question then is that a functioning nodule or not? And a common way of investigating that is to do a radioactive iodine uptake and scan. A functioning nodule will show an intense area of increased activity and then suppression in the rest of the gland because there's a decrease in TSH. If one has not recognized Graves' disease, that's going to show a general increase in size, and it will show a diffuse increase in uptake. And then the last pattern will be Hashimoto's, in which one will see very little activity because release of the T4 will suppress the TSH, and there won't be any activity in the residual normal cells. We'll limit our discussion today to Graves' disease. Note that Graves' disease is going to present with hyperthyroidism or thyrotoxicosis, exophthalmos, and pretibial myxedema. These will correlate as well with the symptoms which we've discussed that are going to group into those that have an increase in BMR. So that's the warm, sweaty hand, the weight loss despite appetite, and the heat intolerance. The increase in the sympathetic nervous system, which gives the anxiety and the tremors and the staring eyes. The effect on the muscle, remember we're talking about atrial fibrillation in the heart and weakness and atrophy in the skeletal muscle. And then in the bone, we can see osteoporosis and an increase in calcium. The pathophysiology, as we've discussed, this is a type 2 hypersensitivity, which means if we're talking about the thyroid gland, the TSH receptor antibodies are going to stick to the outside of the thyroid cell where the receptor is found, activating complement, and complement creating the C3a and C5a that attract inflammation. The treatment for Graves' disease really depends a lot on what country that you live in. If we talk about the US, we tend to use gamma-emitting iodine, I-131, and that destroys the gland by radiation, and then you replace with Synthroid. If one is in Europe, they tend to treat medically. Beta blockers for the uncomfortable sympathetic nervous system, and then methimazole, which inhibits thyroid peroxidase, the key enzyme in organification. If one is in Japan, they actually do surgery and do a total thyroidectomy. When one looks at hypothyroidism, more than 90% are Hashimoto's thyroiditis. So with the rule that over 90% is all, that's the disease one has to understand. This is a type 4 hypersensitivity, which means that it's cytotoxic T-cell lymphocyte mediated. All of the diseases with cytotoxic mediated inflammation, you can go to the tissue, and when one looks at any of that tissue, one can see all of these infiltrating lymphocytes, which are going to cause apoptosis, both through the granzyme mechanism and through the Fas ligand. And that then can give you early release of the hormone, which can in some patients cause hyperthyroidism. The presentation is going to be that of hypothyroidism. Hypothyroidism, just as we did with hyperthyroidism, has many symptoms that can be grouped. The first group we will use are the general symptoms, basically of BMR. They're going to always be cold, increase weight despite being on a diet, and they're generally going to feel tired all of the time. When one talks about the neuropsychiatric, these patients are lethargic depending on how severe and how long it's been going on. They're often depressed, and they often have a decrease in their mental function. These can go all the way through to myxedema coma. Thyroid interacts deeply with the sympathetic nervous system, and therefore it's going to affect the muscle. That includes the general skeletal muscles that we use for contraction, and these often present with weakness, but also with the heart, in which we can see a decrease in the heart rate. Another critical area that occurs in women, and this is mostly a disease of women, is reproductive. And in this condition, they get abnormal menstrual cycles, and this can be a cause of infertility. The natural history, because this is a cytotoxic mediated, is actually one of years to decades. And it's important to think through that you're going to be seeing patients when they're symptomatic, but they've had the disease for a long time before that. Presumptively, at some point in their life, they're all going to present as normal. But it's important to note, even when the patient is completely normal, you're going to find the antibodies, the anti-TPO and the anti-thyroglobulin, for years before there's any meaningful damage to the thyroid gland. Early in the disease, one can see from destruction this release of the T4. This is T4 here, and this is TSH here. So early in the disease, with that destruction and the release of the preformed T4, you can see a hyperthyroid patient. And then we're going to go through a period of compensation. This is going to be asymptomatic, but notice that they've got an increase in TSH despite a normal T4. And there's lots of arguments in medicine about whether one should treat at this point or not. The two groups we tend to treat in this are our infertility patients and women who are pregnant. But eventually, when more than 80 to 90% of the gland is destroyed, even a high TSH can't compensate by driving the remaining cells hard enough. And so one sees this marked increase in TSH, and despite that, a decrease in the T4. And these now become symptomatic patients. What should one do when one has diagnosed Hashimoto's? Remember that this is an autoimmune disease, and almost all of these cytotoxic autoimmune diseases are associated with the autoimmune polyendocrineopathy syndrome. And this is associated with diabetes mellitus type 1, with adrenalitis. These are all cytotoxic mediated immune diseases. So if you have one affected, one should get a family history and go checking the other organs. The treatment of hypothyroidism is very straightforward. You just replace the T4, and that's commonly Synthroid in America. That brings us to the end of this discussion. Thank you for your attention, and we hope to see you with the next video.